us here. I'm going to have Mark Mallory introduce him because Mark trained with Bruce, under Bruce, and Bruce is an eminent hepatologist from Seattle. We're very grateful you're here. So thank you very much. And Mark, go ahead and introduce him.
So this is Bruce Tung, who grew up on the mean streets of the south side of Chicago. That's the way I thought I would introduce him. No, he did grow up in Chicago, and then went to MIT, and then afterwards to the University of Chicago for medical school, and then came out to the University of Washington for residency and fellowship, where I first met him, and he's never left. And they've settled down and very happy in the Seattle area. And let's see, Bruce is here this weekend. Everybody will hopefully meet his family tonight with his lovely wife Cecilia and their children Max and Allie, who will hopefully be able to stay up tonight and not be too fatigued. Bruce has got a nice niche at the University of Washington in the sense that he's doing great work in hepatology, but also has really kept his skills up as an interventionalist as well, which is a nice place to be when you're doing work with both the hepatitis as well as primary sclerosing cholangitis, and of course they see some really interesting interventional cases as well. So he's really sort of a jack of all trades as far as that goes, and we can certainly invite any questions along those lines. But he's going to, all right, but he's going to start out today talking about hepatitis B.
Thank you very much for introducing me, Mark, and inviting me out here, and Steve. Thank you for the...
Let me see if I can get the computer working here. I'm going to be having to walk back and forth, so hopefully let me know if I'm in your way. I should mention also, first off, that there's a slight change. The program is, there's a slight typo in the program. For the second talk, I'm not going to talk about hepatitis C. I'm going to talk about something much more obscure, primary sclerosing cholangitis, which I think is a very interesting disease. But if questions come up about hepatitis C, we can certainly talk more about that in the discussion parts. I wanted to talk about hepatitis B for a few reasons. I think probably in the coming years you'll be seeing more of this. There's more awareness about it. There's a lot of new treatments and drugs in development, and because of that there's a push for more education about to primary care doctors for screening their patients for hepatitis B, and so I think then you'll be seeing more of these patients in terms of how to treat them. And because of a lot of these new drugs that are being developed, there's a lot of new data which is hard to keep track of and hard to keep up on, so I think it's good sometimes to kind of see what's new, what kind of new data do we have that would be pertinent to your practice. And also, I think hepatitis B leads to a lot of more confusion in a lot of ways than hepatitis C. It's not something you see every day, and then when you do see it, you're back to thinking, now, how do I deal with this again? And so I'm going to try to update you and kind of remind you of little things. First of all, this is a major global problem, and I think, again, you'll start seeing it more in your practice. Obviously, the areas that are most important are Asia, Sub-Saharan Africa, and actually a lot of the native Alaskan population. There's a very high prevalence of hepatitis B. And you can see in these populations the chronic carrier rate, surface antigen carrier rate, is greater than 8%, and actually more than half of the people in these areas have probably been exposed at some time to hepatitis B. Now you can see in the continental United States that we have a low prevalence of surface antigen carrier rates, less than 2%. But it's still there is still a significant U.S. burden. It's estimated that there's 1.25 million patients in the U.S. who are chronically infected with hepatitis B. And the highest rate of disease is in this kind of 20 to the young adult group. And the good news is that with education, with the availability of the vaccine, and with recommendations for first vaccinating newborns and then routine vaccination of adolescents, that the incidence of acute hepatitis B is certainly decreasing. So you can see here over time from the late 70s to the mid-90s here, the vaccine was licensed here in the early 80s. It took a while for you to see a change, but then the incidence started going down. Screening of pregnant women for surface antigen. Routine immunization of infants started in the early 90s. Adolescent immunization recommended in the mid-90s. and because of that, the incidence continues to decrease. Now, we've all seen this many times, but I just wanted to point out a few highlights of this. There's two main courses that can happen in a patient once they're exposed to hepatitis B. Either they develop acute hepatitis B and spontaneously clear it and then are immune for the rest of their lives, or some patients may be exposed to it and then progress to chronic hepatitis B. And it's important to try to keep a picture of these serologic profiles in your mind to figure out where your patients are. But a couple things. After exposure, symptoms may be 8 to 12 weeks after exposure, and you can see by the length of this bar that if you do get symptomatic acute hepatitis B, it can last 2 to 4 months, okay? But in this patient, they do develop the surface antigen, but they have an appropriate immune response. The immune system is able to clear the virus, and they eventually lose the surface antigen or are able to gain the surface antibody, which is protective against further infection. And you can see in somebody who develops acute hepatitis B, who then clears it and is then immune, they lose their surface antigen by week 24 or by 6 months. And so that's why if you see somebody who's been documented to be surface antigen positive for more than 6 months, by definition that person is chronic carrier of hepatitis B. And if you're going to clear it, you're going to clear it within that first 6 months. Okay. I will note also in yellow, the core antibody, the yellow and the blue, the core antibody develops fairly early on, and at first it's usually the IgM. So the IgM core antibody is a marker of acute hepatitis B, and eventually you lose that and you develop the core antibody, which is the IgG, which is a marker of exposure to hepatitis B. But early on, if you're trying to differentiate somebody with acute hepatitis B versus a chronic carrier, the IgM core antibody will help you differentiate that. I should mention, feel free to interrupt me or ask questions, obviously, if anything comes up or if I'm confusing you. So this is the other end of the spectrum. Somebody who gets exposed is not able to develop the immune response and clear it and develops a chronic hepatitis B. So you can see they do get that core IgM early on, but they never lose their surface antigen. They never gain that surface antibody, which is protective of hepatitis B against reinfection, and they become a chronic carrier of the surface antigen there. And so that's the hallmark of chronic hepatitis B.
Do they all develop anti-E?
No, and thank you for pointing that out. I'll show you a couple slides later that this is kind of the general picture of chronic hepatitis B, and there's several different subsets of patients who have chronic hepatitis B. There are inactive carriers who will develop an E antibody, but there are patients who have ongoing chronic inflammation and have active hepatitis B, and usually those patients will stay E antigen positive and they will never develop that E antibody.
On patients that have the acute course, clear, lose hepatitis B surface antigen, do those patients totally eliminate viral DNA, or do they still have some DNA, some hepatitis B DNA trapped to it now?
That's a very good question. It used to be thought they did lose it because we couldn't detect it, and over the years with more ultra-sensitive techniques, you can actually isolate minute amounts of hepatitis B DNA from hepatocytes in those patients. And that's really well shown by the transplant situation. If you take a donor who looks like they've had acute hepatitis B, like they've been exposed to hepatitis B but cleared it. So these are patients who are surface antigen negative. They have but a core antibody positive. If those become transplant donors, if you donate their organ to somebody else and then they get immunosuppressed, there is a risk of developing reactivation of hepatitis B post-transplant. So even the patients who appear to clear acute hepatitis B, there are minute bits of hepatitis B DNA often in their hepatocytes. In reality, though, unless it's an unusual transplant situation, it doesn't become clinically important. Those patients generally are protected from reinfection or reactivation or any type of clinical consequences of hepatitis.
What if that patient, if the individual patient isn't a donor but is cleared hepatitis B, and then sometime in their life they become immunocompromised, immunosuppressed, say they develop some malignancy and are on chemotherapy, would they reactivate hepatitis B in that setting?
That would be extremely rare. That would be extremely rare. I mean, and you raise a good point, and we'll talk about that a little later. That does become a very important clinical problem for patients who are in the inactive carrier stage. So these are patients who are surface antigen positive but don't seem to have any active disease. Those patients, certainly when you immunosuppress them, give them steroids, give them chemotherapy, they're at high risk of reactivation, and actually those people, the recommendation is that they get put on antiviral medication before you expose them to immunosuppression. But those patients, the people who have cleared and have surface and core antibody don't seem to have that clinical problem.
Does Remicade influence any of this?
There's been a concern about that, and theoretically there are reasons why it might, but clinically it hasn't been an important problem.
I'm sorry, so you said if you have someone who is inactive, antigen positive, if they're looking at immunosuppression, that's someone who should be on an antibody.
Yeah, and there'll be more slides that'll kind of...
So that's just steroids and not Remicade?
Right, I mean, yeah, we have the most data on steroids, and then for patients with leukemia who are undergoing chemotherapy for treatments for leukemia. And for Remicade, it hasn't been, so far, hasn't been an obvious problem.
What would you do if you were going to institute Remicade in someone?
I would watch them carefully. So there's a different clinical course of hepatitis B depending on when you're exposed to it. The patients in Asia generally are exposed to hepatitis B at birth through vertical transmission, and when you're exposed at an early age, you actually have an extremely high rate, 90% or greater, of becoming a chronic carrier. Okay, and it's exactly inverse to the likelihood of being symptomatic. So patients in Asia who are born and acquire it through vertical transmission, 90% of them become chronic carriers, but very few of them develop jaundice or any clinical signs of acute hepatitis. And it's the opposite when you talk about patients in the U.S. who are exposed as adults, either through injection drugs or through sexual transmission. The incidence of symptomatic infection is much higher, maybe up to 50%. But the chance of becoming a chronic carrier if you're exposed as an adult is probably only in the 5 to 10% range. So that means that not everybody who develops acute hepatitis B as an adult needs to be treated immediately, because the majority of them are going to clear it spontaneously and then be immune for the rest of their lives. Okay, so this is kind of I'm going to show you a couple busy tables that show kind of a few of the serologic profiles that we're talking about. I think most people are familiar with these. Patients who've either been exposed to hepatitis B and recovered, or patients who've been vaccinated. Those are patients who are going to develop the surface antibody, and that surface antibody confers protection against reinfection. Okay, again, the difference between these two groups, if you've actually been exposed to it and recovered, you also will have a core antibody, whereas if you're just vaccinated, you'll just have an isolated surface antibody. Now, another pattern that you sometimes see, and that raises a lot of confusion, is that you'll see people who have an isolated core antibody, but they don't have a surface antibody. And these are patients who actually usually are in this category, that they've been exposed in the past, they've recovered from it, and the core antibody shows you that they've been exposed to it. And what happens over time, over a long enough time, the titer of this surface antibody just drops below the detection of the assay. Okay, and so the question is are those patients actually protected? What we found is that when they're reinfected or re-exposed, or if you revaccinate them, they actually have a very brisk memory immunologic response, and clinically reinfection does not appear to be a problem. So the general recommendation is patients in that category don't need to be revaccinated. They're still considered to be protected. Okay.
Are there any issues with those people as transplant donors, more so than the antibody positive persons?
More so than which antibody positive?
Hepatitis B surface antibody negative, hepatitis B core antibody positive. are there any increased issues for them as a
Donors.
donor?
Yeah, absolutely. That without any prophylaxis, if you take an isolated core antibody positive donor and transplant it into somebody who's not protected, that they have a greater than 50% chance of getting hepatitis B post-transplant. So if we're talking about a recipient for liver transplant, we go through a separate consent process, ask them if they'd be willing to accept a core antibody positive donor. We make sure that we only choose people who already themselves have core or surface antibody, and we also prophylax them with antiviral medications. So it's one way to try to expand the donor pool, but you have to choose and use it in the right situation. Okay. Now, and then as I was talking about before, to differentiate acute from chronic, in a lot of ways they're going to look the same. They're going to be surface antigen positive, core antibody positive, and the hallmark of the difference is that the IgM of the core antibody will let you know that the patient has had a recent infection. Now, if you take, for the most part, the patients that you're going to see and that are going to be the treatment decisions that you're going to want to try to figure out are these patients with chronic, so the patients who carry hepatitis B surface antigen for greater than 6 months. And as you can see by all these plus minuses and so on, that there's a lot of different groups of chronic hepatitis C. So I'm going to take this line here and expand it and talk about some of the different patient profiles that you can see with chronic hepatitis B. And this is, I think, where most of the confusion lies. I think you can usually break people down into, these are patients who are chronic carriers for surface antigen. You can break them down into 4 basic categories. Now the reason for the confusion is, well, there's several reasons, but one of them is that even if you're in one of these categories, it's not a static thing, that patients can move from one to the other and back again. And so unlike hepatitis C, where you have chronic hepatitis C and you'll have it for the rest of your life unless you're adequately treated, in hepatitis B, you can move around a little bit. And so you have to stay on top of these people and figure out where they are. So I think to start with, there are 2 main ends of the spectrum, and that's going to be this column here, the inactive carriers, and this column here, which is the chronic e-antigen positive hepatitis B. Those are the 2 main classic ends of the spectrum. So an inactive carrier is an inactive carrier of the surface antigen, but doesn't have any evidence of ongoing disease at the current time, any ongoing liver damage at the current time. Okay, so these are patients, even though they're surface antigen positive, they have very low viral loads. They're not going to have any elevations of their transaminases, and if you happen to biopsy them, which is not something that I'm recommending specifically, but if you did, you wouldn't see any active inflammation going on. Okay. And actually, I should qualify this normal. There can be patients who have had a lot of active disease in the past who then convert into this inactive carrier category. And they might have had enough disease in the past that they've developed significant fibrosis of their liver. What we're talking about in terms of histology here is more the inflammatory component as opposed to any fibrosis. Okay, so does that make sense?
Do you ever see those guys become antigen negative?
Surface antigen negative? Yes. So these patients, and I should mention, if you're an inactive carrier, you should also be e-antigen negative and e-antibody positive. There is a spontaneous conversion rate of surface antigen, although it's rare. It's less than 0.5% per year. But you can see, without any treatment, spontaneous loss of surface antigen and gain of surface antibody. And that's fantastic when you see it. It's very rare.
That patient, you can tell that you actually have cleared it.
Yeah. Although I will mention that because we don't understand a lot about this. It's also extremely rarely those patients can revert, and that surface antigen reverts. So you're never completely out of the woods. But again, that would be a rare event on top of another rare event. But it can happen. But in general, we say you look clear. Doesn't seem to be a problem. But it's not something that somebody that I would feel comfortable saying goodbye, I don't ever need to see you again. It is somebody that you would follow up on. A couple things probably have changed. One is it's been clearly shown that that reversion can happen. And also now, because we have more treatment options for hepatitis B, there's more that we have to offer if they do have active disease. And so for those reasons, probably we don't just want to send them away. What we tend to do, I tend to send them back to their primary care doctors and say, hey, you know, recheck the serologies, you know, every year for a couple of years. And if the surface antigen comes back, let me know, sort of a thing.
Age of acquisition, does that have anything to do with where they're going to fall in this, or?
Yeah, it does, and it'll come into play when we talk about this, and I'll get to that in a sec, but that's a good point. So that's one end of the spectrum. And the other thing I should mention is now we have these ultra-sensitive PCR assays for detecting the virus. And so now we have these virus levels that, you know, we don't really know what to do with. In the old days, when there was no PCR, the DNA was detected on these hybridization assays, and the detection limit was about 1 million copies. And anything above 1 million was considered positive, was DNA positive. Anything below about 1 million was negative. And so a lot of these lower levels, we're talking about 10,000 or 100,000, they were all considered negative. And now that we have these more sensitive assays, we need to figure out what to do with them. And we still haven't entirely figured that out, but we have at least a little bit more idea. So getting back to this other end of the spectrum, e-antigen positive chronic hepatitis B, this is kind of what's been classically considered in the past chronic active hepatitis B, or the patients who seem to have active disease. So the e-antigen is positive, which is the marker of active replication. They will have high virus levels. A general threshold is about 100,000 copies, although again, that's not a strict line in the sand. Some people can have active disease for slightly less. Oftentimes this value in these patients will be in the billions, okay? They'll have elevated transaminases reflective of ongoing liver inflammation, and sure enough, when you biopsy them, they'll have active inflammation. And these patients are the patients that you're going to be thinking about treating, okay? Because it's important to keep in mind that the treatments that we have, none of them are good at inducing seroconversion of the surface antigen. They're not even that great at changing the e-antigen to e-antigen negative. What they try to do, though, what the goal is to turn these patients with active disease into inactive carriers. Okay. So in general, if you're already an inactive carrier, those are kind of one of the endpoints of your treatment, and so inactive carriers in general are not going to need treatment. Please.
Is the pre-core mutant in this?
Yes.
And so the only way you pick up the pre-core mutant is DNA levels in it?
Well, good point. This gets to the next thing I was going to talk about. Okay. And these are the two main groups on opposite ends of the spectrum. And now these two columns here are kind of where we start to run into more of the confusion. There are patients who have a negative antigen and a positive antibody, but who seem to have evidence of active disease. They have elevated transaminases and they have inflammation on a biopsy. These patients are called e-antigen negative chronic hepatitis B, and by and large, these are the patients who, if you sequence their hepatitis B genome, carry a pre-core mutant. And I have a couple slides in a second that will show you exactly what a pre-core mutant is. So this would be pre-core mutants here. Surprisingly, they do, because that's another confusing thing. And I'll show you on the other slide. But you would think if somebody has a mutant where they don't make e-antigen, that they would never be exposed and develop the antibody. But the mutation actually develops over time, and so they actually have had an antibody development over time. So this would be the pre-core mutants here, e-antigen negative chronic hepatitis B. And the thing that also to keep in mind is that they can have evidence of inflammation and active liver injury at a viral threshold that's lower than what you typically think. So down to 10,000 copies or more. The last group is a group that we're starting to see a lot more of, which is called immune tolerant. And this gets back to your question about when you get exposed to hepatitis B. This is a group that you only see in patients who get hepatitis B through vertical transmission when they're infected at birth, And so by and large, these are patients in their 20s and 30s who are of Asian descent, usually born of chronically infected mothers. These patients look like they have incredibly active disease. They have a positive E antigen. They have viral loads that are, again, usually in the hundreds of millions, if not billions. But surprisingly, they have normal ALT. And so you see these high viral loads, which are very alarming. You see these persistently normal transaminases that you don't really know what to make of. So one of the big questions, and I should say, when interferon was the only treatment we had for hepatitis B, the studies of interferon showed that there was very poor response in this group. The high viral load and low transaminases predicted a very poor response. So the general recommendation was that not to treat patients in this category. Now we have good antiviral medications that suppress viral load to a great degree. The question is that going to be beneficial to these patients? And the answer is we don't yet know, really. But at least we're starting to look at this group a lot more closely. If you biopsy them, which I often do, a good number of them will have pretty normal-looking biopsies, kind of reflected in the transaminases. But surprisingly, you will see some patients who have ongoing inflammation and fibrosis without any bump in the ALT. And so those are patients that we think about treating. So in this group, we often use a biopsy to help us decide whether to treat them or not.
Is there enough known about the natural history of that group to say anything about cirrhosis and or hepatoma?
Very good question. Not yet, but we're starting to see that data. There was actually a paper that came out in JAMA a few months ago from Taiwan where they looked at viral load initially. They went back, they had stored all the serum, and they went back and PCR'd all the serum now that the technology was there, and then looked at who developed hepatocellular carcinoma. And it seemed like a lot of the patients, that viral load early on predicted the risk of hepatocellular carcinoma. And so the thought is that maybe even the patients who don't have a lot of disease, or a lot of activity in their disease, we should be suppressing their viral load. We don't really know that on prospective data. There are problems with treating people long-term with medications that can lead to resistance, and so we don't really know the right answer for that. Okay, so we've talked about DNA testing, and then here's a slide just to show you there's a million different assays out there to test for hepatitis B. And so when you're looking at a lab slip or a result, you need to kind of figure out what assay is being used and what the limits of detection are. You can see in these initial hybridization type assays, the threshold was only 700,000, so anything below that would be considered negative. But I've already told you that we use 100,000 as a general threshold for considering something high or not, so this was not an adequate assay. Now, most of the times when you get a viral load, it's going to be a PCR-based assay, and it'll go down to the hundreds, if not even lower than that. But it's just important when you look at that lab slip that you make sure you know what the limits of the assay that are being used by your lab. The other thing I want to talk briefly about is genotypes, because you'll be reading more about this in years to come. The bottom line is there are a lot of genotypes. We still don't know exactly what to make of them and how they change treatment decisions. So unlike hepatitis C, where obviously genotype is paramount in terms of trying to make decisions about treatment, and it changes your course of treatment and so on, in hepatitis B, it doesn't change your treatment just yet. There are 8 known genotypes. There is a geographical variation, and there's some studies coming out that certain genotypes carry with them a greater risk of hepatoma or a greater risk of progression to cirrhosis, but not enough to change your practice at the current time. And again, you don't need to know this yet, but you might in the future, that in the US we tend to see genotypes A and sometimes D and G, and the ones that are predominant in Asian patients are genotypes B and C. And I'm not going to say a lot more about genotype. So this gets back to the pre-core issue. In the, you hear this pre-core mutant. What is a pre-core mutant? Well, in a normal wild-type virus, there's the C gene, which the translation product is going to be the E antigen. And there's a pre-core region that's transcribed just upstream of that, which starts this process going. So here's the normal. There's the start codon 1, start codon 2 with the pre-core region, and then here's the core region, which translates eventually to the E antigen that you detect, and that's a marker of active replication in the wild type. Now, over time, you can develop this precore mutation where a stop codon mutation develops in that precore region, which leads to premature arrest of the transcription and translation. And so this precore mutation, because of that stop codon, doesn't make the E antigen. So the E antigen is negative, okay? But it doesn't mean that the virus isn't active. The virus is still actively replicating. It's just not making that E antigen. And again, these patients typically are E antibody positive. Clinically, this is the distinction that is sometimes hard to make. Because precore mutant patients are E antigen negative, trying to distinguish them from the inactive carriers can be tricky. Now, if you look at this diagram, it seems like it would be fairly simple, that if you look at the ALT or you look at the viral load, you should be able to tell a difference. But you can't always do that. What if the ALT, your upper limit at your lab is 60 and the ALT is 70 and a viral load is right at 10,000? Is that an inactive carrier, or is it somebody who's got active disease and precore mutation? And again, you may check the ALT several times over the several months, and it may bounce in and out right around that upper limit of normal. So in those patients, there's a send-out lab where you can test specifically for the precore mutation, but in practice, I don't really use that. I know some hepatologists do. We tend to use biopsy and treat based on any evidence of active inflammation or significant liver injury. So the precore mutant patients are a little trickier to treat than your standard active hepatitis B patients because, and there's for a couple reasons. The durability of the treatment response is lower. If you treat them for a while and then you stop treatment, they almost invariably continue to flare. And so the other point is that because they don't have E antigen, you can't look for conversion of that E antigen to E antibody as an endpoint for your treatment. So these are patients without a clearly defined endpoint of their treatment who have a high risk of re-flaring when you stop treatment. And so in general, patients with precore mutation are thought to require long-term, if not indefinite therapy, which is a big deal. So making those treatment decisions at the beginning are very important. So what are the ideal goals of treatment, or what are the goals of treatment? I think we'll talk about the ideal goals of treatment first and then talk about where we are now. Obviously we want to prevent people from dying related to liver disease. We want to prevent people from progressing to cirrhosis or a cancer. And if possible, we'd love to permanently eradicate the virus. Now, in reality, none of the treatments that we have do this with any great degree. The treatments that we have can do this, but trying to choose the right patients to treat and the patients who don't need treatment is one of the challenges.
That's even true with, I thought interferon had, in fact, eradicated some disease, and the reason why interferon hangs around.
I think when people talk about permanently eradicating the virus, the best that you can aim for would be surface antigen seroconversion. So loss of that surface antigen, gain of that protective surface antibody. And I'll show you the data of it. It can happen at a small percentage. And actually now we're starting to see that maybe it can happen with prolonged treatment with some of the oral antivirals as well. But again, those patients still may have, microscopic or minute amounts of hepatitis B that can reflare. So anyway, so here's the list of the currently approved treatments for hepatitis B in the years that they were approved. For many years, there was just interferon alone. In 1998, lamivudine was approved. 2002, adefovir or Hepzira. And just last year, entecavir or Baraclude was approved, and pegylated interferon, the Roche form, which we're all familiar with in treating hepatitis C, was approved for hepatitis B as well. So I'm not going to talk about interferon because I think that's mostly supplanted by the pegylated interferons, but we'll talk about, or I'll show you the data for these other 4 treatments, and you can hopefully try and decide for yourselves which of these looks like the best treatment. And it's not, there's no blanket statement. I think for each patient there are pluses and minuses, as it is with hepatitis C as well. So what when you're looking at these studies, one of the things to keep in mind is what is the endpoint of the study that is most useful or most important, and that's tricky. You know, they're doing typically 1 year or 2 year studies and having endpoints at the end of the study that you're supposed to draw conclusions from, which may not necessarily, these are surrogate markers for those ideal goals of treatment. Again, we want to prevent people from dying from liver disease, we want to prevent people from getting cirrhosis, but really in these 1 or 2 year studies, you're not going to see death, you're not going to see cirrhosis, you're going to see some of these other surrogate markers, and we have to decide for ourselves, are those reasonable surrogate markers for the real important long-term benefits? Because obviously to do a study that shows those long-term benefits, you need to have hundreds of patients over many, many years, and those are difficult to do. But you'll see from these studies, one of the things that they'll look at a lot is the loss of the E antigen in patients who are E antigen to start with, and seroconversion would be the loss of that E antigen, but also the gain of the E antibody. And that's important because that's a more stable form, that if you just lose E antigen but you don't gain the E antibody, that when you stop treatment we know there's a high risk of it reflaring, whereas if you actually seroconvert completely, you're more likely to maintain in that inactive phase. You know, we inflammation improve and we'd like to see the ALT normalize, but those things aren't really important unless they persist after you stop the treatment, okay? This is what we were talking about. We would love to see seroconversion of the surface antigen, but in reality with the treatments we have right now, that's not something that we see at a high level, and hopefully that's something that we'll see more of with new treatments. So just a word about E antigen. This is data from Germany in a large trial of interferon. This is not pegylated interferon, but typical interferon treatment. And this is long-term follow-up of these patients. And so they treated some patients with interferon, and they had a placebo arm. And what they showed was that the survival, this is mortality, their survival in patients who cleared the E antigen was great. And it didn't matter whether they cleared it because they were treated or whether they spontaneously cleared it. We had talked about some patients spontaneously clearing antigen. E antigen spontaneous clearance is probably about in the 2 to 5% per year range. And so patients who spontaneously cleared E antigen did extremely well, whereas the patients who never cleared the E antigen, whether it didn't respond to treatment or through placebo treatment, had a worse survival. So I think this shows that using E antigen seroconversion, or actually in this case loss, as a surrogate marker for mortality has some merit. And so that's why when we interpret these other studies, you know, there's so much focus on the E antigen status. So one of the biggest questions that you face when you see these patients is, who do you treat? You know, you see all these patients in these different categories. Do you need treatment? Do you need treatment? And unfortunately, what's out there published adds to the confusion. There are two main types of guidelines that I'll show you a little bit of, and what they recommend is different. And so you'll have to decide for yourself who you believe or what you feel comfortable to practice. But do you base decision on treatment only based on a liver biopsy? You need to see a certain amount of inflammation or fibrosis. Do you base it on that viral load no matter what the transaminases look like? Does it matter about the E antigen status? Do they have to have elevated transaminases to treat, and if so, how high? Okay, so I'll show you those two guidelines. This is the AASLD Practice Guidelines, which were written by Anna Locke and Brian McMahon, and they recently updated them. And if you go to the AASLD website, these are published on there. But they actually are fairly conservative about their treatment. They basically say that they don't care what the E antigen status is in patients who have an ALT that's less than 2 times the upper limit of normal, that they don't treat them, that they follow them. Okay? That if the ALT is greater than 2 times the upper limit of normal, reflecting inflammation, that they use a viral threshold of 10 to the 5th to treat. Okay? And in their guidelines, in patients who have known cirrhosis, no matter what the ALT is, they would use a threshold of 10 to the 5th to treat. Now this is different from, this is a clinical practice guideline that was came out of one of these expert panels at one of the satellite symposia, the AASLD, and then they wrote it up and published it in the clinical AGA journal. And this was Emmett Keefe, but most of the prominent hepatologists got together and said, well, what are we really doing in practice? And they came up with a set of guidelines that was different than what the AASLD guidelines said. They and this is a little bit more confusing because they broke it down into a few more categories. But they said if a patient is E antigen positive, they would look at the viral load next. In general, patients who are E antigen positive are going to have high viral loads greater than 10 to the 5th. And if that patient has elevated transaminases, that's somebody who needs treatment. This is kind of that immune tolerant group that I was talking about. Active replication, but persistently normal transaminases. And this is what I do too. I biopsy those patients, and if they have active disease on biopsy, I treat them. Now in the E antigen negative patients, they used a lower threshold of 10 to the 4th because, as we saw, pre-core mutant patients can have active disease at a lower level of virus. So in these patients who have elevated ALT and 10 to the 4th, they treat, so these would be considered pre-core mutant patients. If they have E antigen negative, have low viral loads and normal ALT, that's the inactive carriers. Those patients are just followed over time. And then this threshold of 10 to the 4th, but normal transaminases, again, that would be like the immune tolerant type that they would consider biopsying and treating if the biopsy showed disease. Yeah?
In your experience, how reliable are the transaminases in correlating with actual disease in the liver?
In general, pretty good. The level of elevation does not correlate with the level of inflammation, as with hepatitis C. But in general, the presence of abnormal transaminases, definitely above 1.5 times the upper limit of normal, usually correlates with some active inflammation. The problem is in those patients who have in the 1 to 1.5 times upper limit of normal, it's a little bit trickier. And so that's the group that's tough. There are also a small percentage of patients who have persistently normal transaminases. Those immune tolerant patients, one of my colleagues at Harborview in Seattle looked at all the biopsies we had done on those immune tolerant patients, and probably about 20% of them had at least stage 2 fibrosis and some inflammation, so it can be misleading. That's why we're more inclined to biopsy them now than we used to, especially since we have more treatment options for them.
So the only patients that you would suggest not biopsying are the healthy carriers?
Well, I don't think you are obligated to biopsy the patients who have active disease, okay? So if somebody has... So somebody's in this category where they're actively replicating, they have high virus levels, again, they're usually in the millions. They have elevated transaminases. You're going to, for the most part, treat them no matter what. So the biopsy is not necessary to make your decision to treat or not. Okay, and that's different from hepatitis C, where you may have patients who are genotype 1 who the biopsy is really going to help you decide. Because the treatments that we have in general don't have a lot of side effects, unlike the hepatitis C treatments, and are very well tolerated, those patients don't need a biopsy before you treat them. Oftentimes we will biopsy them mostly for information if the patients really want to know their overall where they stand and their prognosis. We offer them a biopsy, but we don't require it. I mean, it's useful for prognosis, and the other place it may be useful is somebody who has cirrhosis or advanced bridging fibrosis. You may be more aggressive about screening for hepatocellular carcinoma. But in terms of decision to treat or not, because the treatment is so well tolerated, it doesn't make that difference. Okay, now, so in the same expert symposium for cirrhotics, they said, we're going to use in somebody who's cirrhotic, you're going to want to have a lower threshold for treating them because you want to suppress any viral replication that could decompensate them any further. So they said anything greater than 10 to the 4th in a cirrhotic, they would treat with antiviral therapy. And again, I would mention that in general, you're probably going to want to avoid interferon in patients who are known to have cirrhosis because of that risk of decompensating their cirrhosis. And in patients who have decompensated liver disease, you may even go lower, and then obviously refer for liver transplantation if it's appropriate for that patient. You know, there are data that show that you can, even in patients with decompensated liver disease, if you treat them with oral antiviral therapy, you can improve their Child-Pugh scores, and you can actually delay or prevent transplant in some of these patients. So we still, we do the liver transplant workup as that safety net underneath, but we still try to treat them and prevent them from progressing to the need for transplant if possible.
When do you use immune globulin now?
Immune globulin? Immune globulin, really the main time we use it would be for a immediate prophylaxis, post-exposure prophylaxis, or we use it in infants who are born from surface antigen positive mothers. So, you know, all newborns get vaccinated for hepatitis B at birth now, but for patients who are, for babies who are born to surface antigen positive mothers, there's still that window of time in that first month until that first vaccine, that first shot kicks in. So they get immediately immune globulin at time of birth to protect them until the vaccine kicks in.
What would you do with fulminant hepatitis, young person that you're trying to get into liver transplant?
Okay. Yeah, so we talked about acute hepatitis B, and I mentioned that you don't need to treat most cases of acute hepatitis B because for the most part they're going to clear, and only 10% or 5 to 10% of them are going to become chronic carriers. The exception to that would be patients who have acute fulminant hepatitis B or acute hepatitis B with signs of severe decompensation. So the typical hepatitis B is just jaundice, but has a normal, it has not encephalopathic, has a normal INR, and they seem clinically stable. You don't need to treat them. Patients who have acute hepatitis B who show any signs of encephalopathy or show coagulopathy, you're going to treat them with an oral antiviral medication and also send them to a transplant center. Okay.
I know this is probably heresy, but, you know, most of those people that survive and go on to do very, very well, and most people believe that the problem is an overactive immune system. Has anybody looked at taking those fulminant viral hepatitis Bs and concomitantly put them on antiviral agents and steroids to blunt the immune system, which they believe is the pathophysiology of the...
Not that I know of in that setting. I mean, steroids have been used they used to do the pulse steroids and then withdraw them quickly to try to get that flare, but not in the setting that you described, not that I know of. So
Well, there's some real old clinical attempts, and it seemed like those people ended up being more active chronic carriers.
Oh, no question about it. Sheila Sherlock used to report that, but I'm asking specifically in the face of the new antiviral agent.
Yeah, no. I don't think anybody has the courage to do that.
Well, yeah.
So let's talk, I'm going to run through the medications we have to treat and try to show you the data to help you make a decision on what to use. So first lamivudine came out, and these are summaries of the two main studies that were done, one in Western populations, one in mostly Asian populations, and they showed really pretty much the same thing, that if you look at the liver biopsy after a year of treatment, that the histologic improvement was significantly greater in lamivudine-treated patients compared to placebo, okay? When you looked at the e-antigen seroconversion rates, and again we talked about why that's important, again, lamivudine was better than placebo, but also the bottom line is after a year of treatment, the seroconversion rate is not that great. It's only in the 16 to 17% range, okay? Now the good news is if you continue therapy with oral antivirals, that can increase over time, but after 1 year, this is kind of what we're talking about. Now this is data that I alluded to before. This is a prospective randomized study in Asia where they took patients who already had fairly severe disease. I think these are patients who either had bridging fibrosis or cirrhosis at baseline, and they randomized them to lamivudine or placebo. and they followed them over 3 years. And this study, and this is actually 600 patients, this study was stopped early because there was a very significant decrease in decompensation of the liver in patients who were treated with oral antiviral therapy. So the endpoints here were death, need for liver transplantation, varices, a significant increase in the Child-Pugh score, any of these signs of really decompensated liver disease. So this is proof that in patients with cirrhosis or advanced disease, oral antiviral therapy delays or reduces the risk of decompensating that liver disease.
Was that treatment for a year or ongoing treatment?
This is ongoing treatment. So they kept people on their treatment. So now the big bugaboo obviously with lamivudine is resistance, and this is really why lamivudine, despite these good things that I've shown you, isn't really used that much anymore, and I think its days as a first-line agent are really gone. There's a YMDD motif in the polymerase which is very susceptible to resistance, and that resistance rate increases the longer you stay on the lamivudine therapy. And when you develop resistance, the viral load goes up, the transaminases go up, the liver injury starts up again. And so you can actually also get a very severe flare when you develop that resistance. Now here's some data from Hong Kong that showed, again, in blue here, this is the development of resistance on lamivudine after 1 year, 14%, 2 years, 29%, 3 years, 56%. In general, we tell patients there's about a 20% chance per year of getting resistant while you're on the lamivudine. And you can see, again, one of the endpoints of treatment is the loss of the E antigen, and it's fairly similar. So when we were treating patients with lamivudine, it was kind of like a race between trying to get that E antigen seroconversion before you develop resistance. Because resistance levels are so high, we don't, again, really tend to use lamivudine that much anymore. So Adefovir was the next drug that came out, and I'll show you some of the data on this. Again, this is compared to placebo after a year of treatment. You can see histologic improvement was significantly different, and this is about in the same range as we saw with the lamivudine. When you looked at the secondary endpoints of these trials, suppression of the viral load to non-detectable limits, significantly better with the drug, with Adefovir, although not the majority by any means. Half the people normalize their ALT, and here's the seroconversion rate. Even though Adefovir is more potent than lamivudine, the seroconversion rate after 1 year is no better. In fact, it's worse. Whether that's statistically significant, we don't know, but it's certainly no better. Now the good news is, and this is follow-up data that was presented at the European liver meetings, when you continue Adefovir for several years, so this is 1 year, 2 year, 3 years, you can see that you start to increase that seroconversion rate. So the good news, at least with the oral antivirals, and I think as a group it probably is true, is if you keep them on therapy longer, you have a greater chance of developing that E antigen seroconversion. The problem is it's an open-ended therapy. You don't know when you start a patient on treatment how long they're likely going to need to be on it, and some patients really want to know that, and you can't usually tell them. The other good news, when we talked about what kind of endpoints for studies are important, E antigen seroconversion is important, but I think we would all agree that if fibrosis in your liver biopsy improves over extended therapy, that would be a very good thing. So this was just presented at the liver meetings in the fall, and this is long-term follow-up of patients who were treated for 4 and 5 years with Adefovir, and what they showed is that fibrosis actually improved in a majority of patients after extended therapy, and only a small percentage, less than 5%, had worsening of their fibrosis while they were on treatment for 4 or 5 years. Okay, so this is further data that you're actually getting a clinically meaningful improvement with prolonged therapy with these medications. Now, with Adefovir, I should mention that there is some concern, a little bit of renal toxicity, although it's not a major concern. When they did, this was initially a drug developed for HIV, and in the doses that they studied for HIV, which was a 30 milligram dose, there was a proportion who developed an increase in their serum creatinine. Now, when they studied, this is the dose that we use in hepatitis B, there was no such increase in the creatinine, and although now with longer-term follow-up, out of hundreds of patients, there were 3 in the long-term safety study who did increase their serum creatinine greater than 0.5, and they all resolved, although 2 of them had to have their drug discontinued. And because of this information, if you do treat somebody with Idefovir, I think you're obligated to monitor their creatinine periodically just to make sure this is not a major issue. We don't see it very often. In fact, in my practice, I don't think I've ever stopped Idefovir because of a rise in creatinine, but I feel obligated to monitor it.
You start the patients at 10 milligrams and titrate to their viral titer?
No, 10 milligrams, and they stay on that. You do need to dose reduce if patients have a decrease in their creatinine clearance. So all of these drugs are dose reduced for renal, for creatinine clearance, but it's usually a creatinine clearance of 50 or below before you have to dose reduce any of these medications. Other than that, it's the same treatment, the same dose throughout. Now that we've had Idefovir for some time, what we can see is, like lamivudine, the risk of resistance is going up. So the initial studies after 1 year and 2 years showed a very low resistance rate, and that was very encouraging. Now we're starting to see it's going up again. And I think this is going to be true of this class of medications in general, that obviously it's not a matter of if, it's a matter of when and to what degree. So it's something to keep in mind that Idefovir resistance does develop, although at a much lower rate than lamivudine. And in fact, this table shows that if you compare the resistance rates over time, it's still significantly better with Idefovir than it is with lamivudine.
With this drug, do you use e-antigen negativity as an endpoint where you would stop treatment?
Yes. And in general, for patients who start out e-antigen positive, the endpoint of treatment is to seroconvert the e-antigen to e-antibody, and then typically you would treat 3 to 6 months beyond that seroconversion and then stop therapy in an appropriate patient. Okay? If you stop therapy, and it's been shown that if you extend therapy for that 3 to 6 months beyond that seroconversion, they're less likely to revert when you stop therapy than if you do it right away. So entecavir was approved in the spring of last year, and in their studies, since lamivudine since it's newer, they actually compared entecavir to lamivudine as opposed to the placebo-controlled studies I showed you before. And you can see that histologic improvement, even compared to lamivudine, was statistically better with entecavir. Okay? And this is both, they had 2 studies, one for e-antigen positive patients, one for the e-antigen negative precore mutant patients. And that was the same in both studies. The degree of viral suppression is greater with entecavir than any of the other medications that we have. If you look at what % of patients became non-detectable by PCR, a majority of the patients in both groups, but significantly better with entecavir than lamivudine. So a stronger antiviral effect with entecavir than lamivudine. And this gives you an idea of the degree of suppression. In an e-antigen positive patient, the mean reduction of viral load is almost 7 log copies. So that would be, if somebody starts out at 1 billion copies, 10 to the 9th, down to 10 to the 2nd, okay? So down to 100. So excellent virologic suppression. Less so, but still significantly better than lamivudine in e-antigen negative patients. And then they also had a study for patients who were already resistant to lamivudine, and obviously there was a significant improvement. But this, I didn't show you the data, but both Idefovir and entecavir are effective in patients with lamivudine resistance with that YMDD mutation. This is the % that had normal ALT, which is also better than lamivudine. And here's the seroconversion rate. This is disappointing. This is has the best suppression of viral load of any of the medications that we have, but still, after a year of treatment, the e-antigen seroconversion rate is not any better than compared to lamivudine. There's no statistical significant difference. It's only about 20% in that first year. And that is disappointing. So still, it's important to realize, even though it's better than lamivudine, these are patients that likely are going to need at least several years of treatment. 1 year of treatment is not going to be adequate for the majority of these patients. Now this is an update on that. This is with a little bit longer treatment, and this was presented at AASLD in the fall again. I don't have the I'm not sure what the mean length duration of treatment was on this, but people were treated for a longer period of time. Again, we're starting to see the seroconversion rates increase with extended therapy. And encouragingly, a very small percentage of these patients have now started to lose their surface antigen. None of them have gained the surface antibody yet, so they're kind of in that in-between zone. But at least we're starting to see some effect with that. And up until this data were shown, this class of medicines had never really shown that. It had only been the interferons that showed surface antigen loss. So this was intriguing, but we still don't know enough about that to know what that means. And just a quick slide to show you that entecavir is incredibly well tolerated. The incidence of adverse events is high in all these studies, but when you compare the lamivudine to placebo, there was no increase, and when you compare the entecavir to lamivudine, there's no difference in any of these side effect profiles. Now, how about entecavir resistance? Well, so far so good. We only have 1-year data. In patients who had never been treated for hepatitis B, no resistance after 1 year of entecavir. There was 1%, 2 patients or 1% resistant in the patients who already had lamivudine resistance who were treated in a separate study. So far that looks, but again, I think it's a matter of when and how much, but not if. So lastly, I'm going to show you the data on pegylated interferon, and this is going to be data from 2 trials and this is kind of their trial design. It was a year of treatment followed by 6 months of follow-up. Okay, kind of more like the hepatitis C trials that we've seen, and they were randomized into 3 groups: either pegylated interferon alpha 2A alone, or lamivudine, or the combination of the 2. So this is the first study, or the only study I'm going to show you that had combination therapy, which people were very interested in. So here's the e-antigen seroconversion rate in the patients who were e-antigen positive to begin with. The patients who were treated with pegylated interferon had a better seroconversion rate than patients who were treated with lamivudine alone. Unfortunately, the combination was no different, in fact a little bit worse, but certainly no better than pegylated interferon alone. Okay, but you can see a year of pegylated interferon led to a 32% e-antigen seroconversion rate, which is better than we saw after a year of any of those other treatments. And this is kind of interesting data that shows you the seroconversion rate over time, that after a year of treatment, you're here. When you stop treatment, in that 6-month follow-up period, there are some patients who are treated with pegylated interferon in these 2 groups who actually develop their seroconversion after you stop treatment in that first 6 months. So there's a delayed response there, where you don't see that at all in the patients who are treated with lamivudine alone. I'm going to skip over that. When they broke it down into subgroups, what are the seroconversion rates by subgroup? Patients, as we saw with regular interferon when we used to do that, patients who start with a baseline high transaminase levels are more likely to develop e-antigen seroconversion with treatment. So for some reason, because they're immunologically primed already, these patients respond well to interferon. And also, the lower viral loads. If you have very high viral loads, here greater than 1 billion or 10 billion, the likelihood of seroconversion is much lower across the board. Just a quick note about, we mentioned genotype. When they looked at genotype here, there was really overall no difference in the 4 different genotypes in terms of response to either the lamivudine or the pegylated interferon. This, I think, there's a question of whether this is significant, whether type A responds better to the pegylated interferon alone, but it didn't have that response and used in combination, and it may just be a factor of the small number, so I wouldn't really make much of this. I don't think genotype in this study really was a major player. Okay, so this is what we were talking about, seroconversion rate, surface antigen seroconversion rates. This is the e-antigen positive study, this is the e-antigen negative study, and you can see that 3% of patients treated with pegylated interferon actually converted their surface antigen to surface antibody after a year of treatment with the pegylated interferon, compared to none in the lamivudine alone group. And this is one of the reasons that people are very interested in the interferons, but again, this is only 3%, and it's a year of treatment, and we all know what the side effects of treatment are like. And by comparison, all the oral antivirals really have very little in the way of side effects. Now, the other thing that's important to realize is the hepatitis B patient population is a lot different than the hep C patient population. When they pulled these data and looked at depression with interferon treatment and how patients tolerated therapy, you can see that the risk of developing depression on interferon is much lower in hepatitis B patients than hepatitis C patients, and this is the same dose of drug. So it's just, points to the fact that the patient populations are very different. Probably their coping mechanisms are different, and so, patients who have a high IV drug rate, probably that was manifesting their poor coping skills to begin with. So patients tolerate interferon better when they're in Asian patients. Okay, so a few summary slides then. Here's a very busy slide that kind of tries to compare all of these endpoints here and all the drugs across the board. And it's a little bit, these are different studies with slightly different patient populations, so it's hard to compare them across the board. But in general, if you look at the loss markers of viral suppression, like the loss of DNA, entecavir has the most virologic suppression. If you look at an endpoint like seroconversion, a year of treatment, interferon has the best response. But again, this is after only a year of treatment, and you're going to stop treatment. Whereas with these oral antivirals, you are going to continue treatment until you get seroconversion. And so these seroconversion rates can increase over time and can catch and surpass the interferon if you continue on treatments long enough. And again, seroconversion you can see with interferon, and we're not really seeing with any of the oral antivirals yet. This gets back to what we were talking about earlier. What is the recommendation treatment guidelines? So for all antivirals, you want to continue for 6 months after you develop that e-antigen seroconversion and then stop. If you don't develop that seroconversion, you're going to continue. And then pegylated interferon, mostly because this is what the trials were done for 48 weeks. The old interferon we would treat for 3 to 4 months. The studies were designed for 48 weeks. We don't really know if you can get by with shorter or whether you need longer. There's actually going to be a study done comparing 6 months to a year of pegylated interferon, but that study hasn't started yet.
Is this all 180 micrograms?
180 micrograms is the dose that was studied. I'm going to skip over that. So, summary table. So here are the treatment options. If you have the typical e-antigen positive chronic hepatitis B, I think any of these are reasonable choices. Well, I should take that. We don't really use lamivudine because of the resistance. I think any of these three are reasonable choices depending on patients. Some patients really want a finite duration of therapy, are not so concerned about the side effects, and interferon might be a good choice for them. Other people want as few side effects as possible, and it doesn't bother them to know that they'll be on a medication for 3-4 years perhaps, and in those patients oral antivirals may be better. In cirrhotics I would avoid interferon because of the risk of causing decompensation. In decompensated cirrhosis I would definitely not use interferon. I put a question mark here mostly because we just don't have any data, although there's no reason to think that entecavir wouldn't be safe in that situation. But we actually have studies in the liver transplant population with these two drugs, and they're safe and patients seem to do well. And as I mentioned, adefovir and entecavir are both effective in lamivudine-resistant patients.
With renal insufficiency, what sort of dose reductions are we talking about?
The dose reductions in renal insufficiency are typically half the dose, and in each of there's usually a table in the prescribing information for all the inserts and all of them on how to dose reduce. Okay. I'm going to stop there and take any other questions.
Great, Tom. Just since you run in the circles of academia and researchers, to me, as I sit down and kind of look at where we've come the 20 years that I've been in practice with HIV, and hepatitis B, and now hepatitis C, we've understood, I think HIV's kind of been almost as becoming our gold standard on how to treat these people. We're looking more at viral titers and all. And if we ever look at HIV therapy, where we've evolved from single drug therapy to multiple drug therapy, from finite treatment to indefinite treatment, and multiple drugs. Anybody in the circles that you run in talking about that?
Yeah, absolutely, and I think your observations are very, very appropriate. Yeah.
If you repeat the question, not
Oh,
the whole question.
okay. Thanks so the question was, what lessons can we learn on hepatitis B treatment from HIV, where the trend has been towards using multiple drugs in combination and for extended periods of time, more of kind of a chronic suppressive type of a treatment. Yeah, and absolutely that's something that's been talked about and thought about. I think there are two issues there. One has to do with the efficacy of the treatment, and the other issue is the emergence of resistance, which obviously with HIV and now with hepatitis B is important. You know, it's been quite disappointing the way that the trials have been done so far, and I didn't show you a lot of this data, but combination therapy has been looked at, either with combinations of these oral nucleoside analogs in smaller pilot studies, or as you saw with the combination of interferon and lamivudine. And none of the data that are available have shown an improvement in efficacy with any of those combinations. So theoretically it seems like it should be, but in practice so far we haven't found that combination. Now there's a question of maybe we should be doing sequential therapy, that with interferon you can prime the immune system in some way, or that you can suppress the viral replication first before you hit them with interferon. And so there's some people who are looking at different sequences of doing that, but again, nothing that's shown any efficacy. The resistance issue is important because, and again, I didn't show you this data, but lamivudine-resistant patients are still susceptible to adefovir and tenofovir. When you start to develop adefovir resistance, those patients are often still susceptible to lamivudine. So in certain patients, you may see on a combination of lamivudine and adefovir, and that's really more to protect against the resistance issue as opposed to an increase in efficacy. Again, the tenofovir resistance we haven't really seen enough of yet to really know the right way to treat that. But hopefully that answers